Just to introduce our next speaker, who's Professor Suzanne Cassidy, as I mentioned. She's a clinical professor of pediatrics of the University of California. She's conducted multidisciplinary specialty clinics for PWS since 1981 and has published widely on her clinical observations and research into PWS. She's a former chair of the Scientific Advisory Board for PWS USA and is currently president of the International Prader-Willi Syndrome Organization. Not alone all that, but she has also recently been named as the 2014 recipient of the annual award for the excellence in human genetics education from the American Society of Human Genetics. Today, Suzanne will discuss an overview of healthcare issues for children with PWS.
Thank you so much for inviting me to be here, and I really appreciate the opportunity to meet so many wonderful people and talk a little bit about Prader-Willi syndrome for a change. They say that learning is done through repetition. Well, you're going to get a lot of repetition. I was asked to talk about an overview of health issues, most of which have already been talked about by somebody. So this was prepared in advance, and I didn't have the opportunity to change it, so I hope that you do benefit from repetition. Let's see. Maybe I'll use this. No, that's wrong. Okay. Page down, I guess. Okay. As you have heard already, and as you know yourself, there are many positive aspects to people with Prader-Willi syndrome, but we've been asked to talk about some of the problems, and so that's what I'm going to do today. That certainly doesn't mean that that's all there is to Prader-Willi syndrome. I have to mention in advance that in spite of what you've heard about research, there really are very few what we call well-controlled studies. So a controlled study is one that has an untreated group and a treated group, and preferably the investigator doesn't know whether somebody is treated or not treated when they evaluate for whatever the endpoint is. And so a lot of what we know about the manifestations and management of people with Prader-Willi syndrome comes from observations or collections of patients to look at them without interventions, or from very small studies with an intervention. So as a result of the fact that our studies are not well controlled, different doctors who specialize in Prader-Willi syndrome and put their information in the literature may approach problems very differently. My information is based on over 30 years of directing a Prader-Willi clinic and conducting clinical research, but it's also based on other people's publications in the medical literature and discussions with other experts in environments such as our international scientific conference that goes along with the International Parent Conference that's sponsored by IPSO, the International Prader-Willi Syndrome Organization. I think it's very important to re-emphasize something you probably already know, which is that the word syndrome doesn't carry any implication other than to say that there are a number of features that occur together more often than by chance alone. For Prader-Willi, as well as most other syndromes, not every affected individual has every finding. And the severity of each finding varies from mild to moderate to severe. And the severity of one finding does not necessarily influence the severity of another finding. And in addition to all of that, other family characteristics, mostly good, but occasionally some bad ones, and life experiences can influence appearance, abilities, behavior, and so we find a great deal of variability among individuals. When we talk about various things like motor milestones or something, we look at the average, but there's always a wide range of overlap. And of course, people with Prader-Willi syndrome can have difficulties or features that are unrelated to the disorder. It's already been mentioned that the course of Prader-Willi syndrome has really changed. Now we can make the diagnosis at birth. We could make it before birth if we knew to look for it, but that typically is not the case. But certainly within a few days of birth, we can now make the diagnosis, which was certainly not the case before about 1981, when diagnostic testing first came in just for the deletion. It really has made a big difference to families especially, to be able to know what the problem is due to stop what we call a diagnostic odyssey of doing a lot of testing to try to figure out the cause. Usually Prader-Willi syndrome was at the bottom of the list of possibilities, so muscle biopsies and all kind of other testing was often done long before a diagnosis of Prader-Willi syndrome was made. Treatment also, or at least management, can also be instituted at a much younger age, and knowing what to anticipate of your child can make a big difference in how you react to those findings. Many issues are now recognized earlier and treatment is started earlier. Growth hormone has come along and made a huge difference in some aspects of Prader-Willi syndrome. We have much more knowledge about health issues and what to do about them based on an increase in research. And there's much more educational material for not just for families, but also for healthcare providers, teachers, and others, so that the outcome in Prader-Willi syndrome has been much improved through our increased knowledge, which in turn has been benefited greatly by diagnostic testing. And that's today. Just as there's been huge changes from the past bringing us to today, I'm convinced there will be huge changes in the future that, if you have a young child, will affect your child. And so it's very difficult when you say, "Doctor, tell me what I can expect for the future." Well, there's no way to know, really. All we can do is look at people who are alive today and tell you something about them. Okay. Like a couple of other people ahead of me, I plan to talk about an age-focused approach to understanding the health issues in children with Prader-Willi syndrome, and I'm going to talk about newborns, that is people under a month of age, infancy up to a year, early childhood from 1 to 5, and late childhood from 5 to 13. And I think the reason that these particular ages were chosen, not only by me, but by Dr. Meehan, is that one of the reasons would be that the American Academy of Pediatrics, which is the organization of pediatricians in the US, has developed a recommended guideline about management of Prader-Willi syndrome, and they broke things down by these ages. You should be aware, though, that most of the issues that I'm mentioning span more than one age, even if I mention it in one of the categories. So newborns are really predominantly marked by hypotonia, which is the most universal finding in this condition, and by the consequences of it. They also have lethargy, and I'm going to be talking in more detail here, but sometimes they have issues related to delivery problems, such as prematurity or post-maturity, which can have their own consequences. So hypotonia is low muscle tone. It's an impaired resistance to gravity. So most of us, and including newborns, are moving around all the time and are easily able to resist gravity. But babies with Prader-Willi syndrome usually are not. And they have very diminished movement and, as you know, a weak suck. The hypotonia is not an intrinsic problem to the muscle. It's a problem of signals from the brain not sending the muscles the messages even at rest that it normally does. And the result is that the muscles are floppy, as we have called them. This is evident prenatally with decreased fetal movement and abnormal position and timing at delivery, which leads to a frequent need for assisted delivery, cesarean section being one of the most common approaches. The severe hypotonia could last a few days in rare cases. Usually it lasts weeks or a few months. Sometimes it lasts a lot longer. The tone in the muscles will gradually improve, but rarely does it improve all the way to normal. And so it is present even in older people. So the consequences of the hypotonia include the fact that the babies are unable to suckle and are, generally speaking, unable to breastfeed. They have a weak suck on a bottle, if any. Frequently, they need a nasogastric tube to be fed, and that lasts, again, weeks to months. And after they are able to take things orally, it often takes them longer to feed. And the result of this difficulty with feeding is that they have difficulty putting on weight and growing, which is called failure to thrive. It's probably not the best term, but it's the one that's being used. There's significantly decreased movement. Most babies are moving around all the time, but not babies with Prader-Willi syndrome. And in fact, that can influence the shape of the head if their head is kept in the same position all the time, because they're not moving it around very much. They tend to have a weak cough because of the hypotonia of the respiratory muscles, and that leads to an increased risk of pneumonia and can also lead to swallowing problems at times. There's an increase in congenital hip problems, often poorly shaped hip joints or dislocated hip joints, and that can occur in 10 to 20%. So the lethargy is the fact that the babies just don't seem to want to move and have very poor arousal and a lot of sleepiness. The danger is to call them good babies. They're nice and quiet, but that's not an advantage for them in any way. They tend to have a weak cry, and sometimes they have trouble maintaining their body temperature, and it drops below normal. So what do we do about the hypotonia? Well, there is no medication that goes directly to the muscle tone, and so what we need to do is actually compensate for the low muscle tone rather than treat it per se. So the most important thing is to assure adequate caloric intake, and that is done by using special feeding techniques. Most babies that I'm aware of have needed a tube that goes through the nose and into the stomach, a tiny little tube. But some can suck on using a special nipple, like the kinds of nipples used for people with a cleft palate. If your palate is open, you can't get you can't have suction, and so they have special nipples and bottles that allow you to basically squeeze in the food when you're feeding the child. The feeding difficulties do resolve, and in many cases they resolve relatively quickly in the first few weeks. And I'm always very hesitant when the neonatologists or other doctors taking care of them want to put in a tube that goes directly into the stomach for feeding, a gastrostomy tube, because pretty soon it's not needed, and then you have a surgical incision. It's gone all the way into the stomach, which is, I'll talk about later. The stomach wall has some issues also that can occur, so we just as soon not disturb it. I spent a lot of time convincing people not to do gastrostomies, but there are circumstances like if there's food that comes back up, milk comes back up and goes into the lungs, that would be an indication that it would be useful to do tube feeding with a gastrostomy. I also think it's important that most babies with Prader-Willi syndrome will not wake up and cry for their meals. So you really have to feed them when you know it's the right time, or when it's been indicated it's the right time, rather than waiting for them to let you know that they're hungry. And it's important not to try to get them to suck for, say, longer than about 20 minutes, because otherwise the work of feeding is more than the caloric value of the food. So you want to try to get them to take the food in a shorter period of time. Families need to make sure that their doctors check for a hip dislocation, and obviously it needs to be treated if present. Usually they do that with thickening the diapers, triple diapering, but occasionally it requires surgery. The children should be referred to services for physical and occupational therapy if it's available, and the parents should interact and stimulate the baby just as they would interact with a baby who was much more demanding. In order for good brain development, it's important to keep stimulating. And even though the baby is sleepy and quiet, it's a very important thing. The hypotonia does slowly improve, but feeding problems can last for months, although there is, as was referred to earlier by Dr. Meehan, there's a progression of through multiple stages of different eating patterns, where they do get to a point where they're sucking on their own quite normally in later infancy. Once the baby is past the first month of age, people do notice that they have become delayed in their motor development. We also notice that there's a higher incidence of the eyes not working together, of squint, or I'm not sure what it's called here, but usually squint in this part of the world, and in the US we call it strabismus. But basically the two eyes are not working together, and frequently one is turned out, although it could turn in, and it's because of hypotonia of the muscles that work the eyeball. Undescended testicles are very common in males, and it's possible that it's at least partly related to the hypotonia, because other causes of hypotonia also have a high incidence of undescended testicles, although there could also be some hormonal issues that contribute. We've heard about scoliosis and how common it is in Prader-Willi syndrome. It can actually occur any time in childhood. Most pediatricians are not used to looking for it in a very young infant, because typically it happens at adolescence in the general population. But it's important that your doctor is encouraged to examine the back, and if it's unclear, do an X-ray to assess for the existence of scoliosis. Gastroesophageal reflux, just like happens in older people, it can occur in Prader-Willi syndrome, and that would show up as spitting up. I think I have a slide later with more detail. Growth deficiency obviously can become apparent in the period of 1 month to 1 year. Sleep apnea, you've already heard something about, and I'll talk some more about it. And hypothermia or fever of unknown origin occasionally occur during this period. In infants now, not newborns, but infants, we want to be sure that the growth and the proportion of weight to height, or the BMI, are monitored closely and frequently, especially in the first year of life. And I prefer it if it's done by a doctor or a nurse or a dietitian on the same scale and the same measuring device, so that there's consistency. The caloric intake can be adjusted accordingly, and we can make changes in not just the volume of formula that babies get, but also in how many calories there are per ounce. And that should be done in conjunction with somebody who's closely following the caloric intake. And adjusting according to the growth charts. And it's important to continue at least partial gavage feeding until the baby is taking by nippling well and under 20 minutes. And some families find that that never occurs, and so they move directly to a cup and a spoon, which is effective as well. Physical therapy and developmental stimulation are critical throughout the early years and perhaps throughout life. There's the importance of lots of interaction with parents and siblings remains. And there's an increased incidence of hypothyroidism. Hypothyroidism, the thyroid, as you probably know, is a gland in the neck that basically controls how fast our engine is running. And if it's there in excess, your engine runs too fast. But more commonly in Prader-Willi syndrome, it might. There's about a 10 to 20% incidence of it running too slowly. And that can actually contribute to hypotonia. So if the hypotonia is very prolonged, it's certainly important to check for that. I assume that hypothyroidism is checked in every newborn here. There's newborn screening for it, but it can happen later as well. I do want to say a word about supplements, and I have to start this by explaining that I'm not a great believer in supplements, but there are those who are very good doctors who are great believers in supplements. So this is one of those uncertain areas where there has to be a discussion between the family and the doctor as to whether or not the child should be taking supplements, and the doctor should definitely know if you're giving the supplements, but not having a discussion about it first. So the supplements that are usually given are those that are involved in energy metabolism, because the thought is that somehow they will improve the energy of the child and result in faster development and improved muscle tone. Those things are coenzyme Q10 or CoQ10, carnitine, and fish oil. Some families who treat their child with these supplements do see what they consider to be significant benefits and improvement in activity and energy and development, and others who give the same amount and the same type see no change whatsoever. I think that's what's important is that that the studies that have been done have not shown deficiency of these substances in people with Prader-Willi syndrome. So you're not treating a deficiency here. You're giving an excess over the normal amount. Secondly, there are no well-controlled studies that show benefit, but there's no well-controlled studies that show harm either. So you're left really basically just deciding for yourself whether or not it's worth the expense to treat with something for which we don't have evidence of benefit, but we also don't have evidence of harm. That's kind of a sensitive topic that, by the way, that many people feel very strongly on one side or the other. Further management in infants is that it's important to evaluate the child for the squint, for the eyes not working together, because if your two eyes see different images, the brain is going to just shut off your ability to see out of one of those two eyes for life. So we want to make sure that treatment is initiated if there's a problem with the two eyes not working well together. And my recommendation is, if available, a pediatric ophthalmologist should be the one evaluating. It's usually treated with maybe a patch on the weaker eye, on the stronger eye to allow the weaker eye to get strengthened, or with surgery to correct the muscle implantation. And it's recommended that every year the child have an eye evaluation by an ophthalmologist in order to catch vision problems, because those also occur, an increase of the need for glasses either because of a lazy eye or because of nearsightedness or farsightedness, which seem to occur in increased incidence in Prader-Willi syndrome. Very important to assess whether the testicles have descended, and if they have not descended, given a few months of life, they should be treated. And there are treatments that are hormonal treatments. They tend not necessarily to help the testicles come down, but to enlarge the scrotum so that if surgery is needed, it's more likely to be successful. Sometimes the testicle will come down in the first few months all by itself. We also, of course, need to evaluate for scoliosis, as you've heard from several people, and refer to an orthopedist for management if it is present. I mentioned the fact of gastroesophageal reflux. This is when food comes back up the food tube, the esophagus, into the mouth, and typically what you'll see is a lot of spitting up and vomiting, and there's some babies who spit up and they continue to be happy, and it's sort of a developmental stage, and they'll be fine, they don't need treatment. But if it's associated with discomfort or crying or arching of the back, then really it should be evaluated. If there's any problem with gagging and choking and coughing and wheezing, or on an extreme, pneumonia due to aspiration, those things really indicate that the gastroesophageal reflux should be treated. Remember, it's not just the arm and leg muscles that are affected by hypotonia, but the internal muscles as well, those that relate to the gastrointestinal tract in particular. The treatment is usually a change in the feedings to maybe thicken the feedings, change the feeding position, make sure the baby stays upright for a while after feeding, or there are medications that can help, and sometimes surgery is needed, but not very often. I believe that babies, once you have the diagnosis, should be referred to a pediatric endocrinologist for a discussion about growth hormone and evaluation as to whether it's needed, and whether you started in the first few months of life or after a couple of years. I think it's good to establish a relationship with an endocrinologist to hear the data and of the benefits and potential risks, and get familiar with the system at the very least. Sleep, you've also heard about sleep apnea, which are basically pauses in breathing. And there's two major causes of sleep apnea. One of them is the brain isn't sending the right signals to breathe. That's very common in very young infants with Prader-Willi syndrome, and it goes away with time. And it's not the part that we're concerned about with growth hormone. It's what we call obstructive sleep apnea, where basically the airway has collapsed during breathing in sleep. And if you have a tendency in that direction, and on top of that, your tonsils and adenoids are growing at a rate faster than the tissues in the throat that they're living in, you can run into some significant, or theoretically you can run into some significant problems with sleep apnea when growth hormone is started. There are also a variety of other sleep alterations. We heard about excessive daytime sleepiness, and there are other what's called sleep architecture problems. But the one that concerns us the most is obstructive sleep apnea. There's a risk for sleep apnea in everybody, but it's increased when children are very young, when there's severe hypotonia, because like any feature, there's a range of severity, when there are respiratory problems, often unrelated to Prader-Willi syndrome or possibly from aspiration, and when there's severe obesity, which obviously is not going to be the case in very young infants. So it's recommended basically that every child have a sleep study, but it's particularly important in those who are considering starting growth hormone. Sleep apnea can be treated. as in the general population where it also occurs. And sometimes it requires removing the tonsils or adenoids, but more often it involves what's called CPAP, which stands for continuous positive airway pressure. So you're giving a little bit of air pressure into the lungs to keep the airway open. And there may be other treatments as well. Okay, I'm moving now into young childhood, where the health issues are listed here. Weight and the onset of hyperphagia or excessive eating is one of the biggest concerns. Growth is a big concern, especially if it is not already being monitored or treated. Visual acuity we referred to already. Scoliosis remains on the list. Sleep problems are still in there. There's a decrease in stimulation of the saliva glands that leads to a decreased fluid in the saliva that can lead to stickiness and dry mouth and little crusts of saliva drying on the lips. And the decrease in saliva can contribute to some dental problems like tooth grinding and can also lead to, may also contribute to articulation problems, the poor formation of words by the mouth. Constipation can be an issue, and as I'll come to later, needs to be aggressively treated. And hypothyroidism we already talked about a little bit. Weight problems in Prader-Willi syndrome have three major causes, one of which is that altered sensation of being satisfied, of having had enough to eat. It's a brain problem in the hypothalamus, a decreased requirement for calories because of not moving as much, and having decreased muscle bulk. And short stature may also contribute a little bit. And then the fact is that people with Prader-Willi syndrome seem to have a very high threshold before they'll vomit, and some people never vomit in their lives. When everybody in the family has a gastroenteritis, the person with Prader-Willi will be the only one who isn't vomiting. So the inability or lack of normal stimulus to vomit associated with a decreased perception of pain, which seems to be common in Prader-Willi syndrome, can lead to people eating vast quantities of food or rotten food or food that are potentially hazardous without feeling discomfort. So the onset of this excessive appetite has typically been said to be between 1 and 6, with most between 2 and 4. I've had a lot of parents lately. Dr. Holland talked about how you listen to what, or Dr. Lawrence used to be listening to what parents had to say about things. And I've heard that a lot of parents say that in the last 10 years or so, my child doesn't seem to have excess eating, and or it happened much later than 6 years of age, and I don't know why that would be or whether it's really accurate, but it wouldn't be surprising if it happened after 6. There's nearly a constant food seeking, but the intensity of that is quite variable, and it's present regardless of whether the person is slim or heavy. The physiologic mechanism that causes the hyperphagia has been the subject of a lot of research and is the subject of a lot of ongoing research, as Jana Lee, I'm sure, will talk about. But we still don't really understand exactly what causes that. There's currently no proven direct treatment, and as I say, it's the subject of a lot of research and drug development, which you will hear more about. If eating is uncontrolled externally, that is by changing environment, the drive to eat excessively will lead to obesity in almost everyone with Prader-Willi syndrome. It's the major cause of morbidity and mortality, illness and death in people with Prader-Willi syndrome. And in early childhood, it can slow down motor development. It can lead to respiratory problems. It could worsen sleep apnea. People who are shoving the food in quickly to try to get as much in as they can choke on the food. And one study done through the Prader-Willi Syndrome Association USA showed that one of the more common causes of death in children with Prader-Willi syndrome is basically choking on a piece of a hot dog or a sausage that gets stuck in the airway. And because of their hypotonia, they don't have the strength to cough it out. And there, of course, can be social problems related to the obesity, and as we heard, self-confidence problems. There's currently no available safe drug, at least in my country, known that's available in my country, known to decrease the urge to eat in Prader-Willi syndrome. I may hear differently later. There have been some reviews of the literature on surgery, and they have shown that there's actually a lot of complications from bariatric or surgery to decrease obesity and a low rate of long-term success. But there are newer techniques that come out pretty regularly, and the long-term controlled studies have just not been done, to my knowledge. So what do we do? Well, it's the same old thing that we heard before from Dr. Meehan, a low-calorie diet. I recommend working with a dietitian. The diet should be adjusted to the level of activity. I want to encourage physical activity as much as possible, which often involves a whole family effort. Food security by doing whatever is appropriate for that child. It may be locking the kitchen, it may be constant supervision, keeping high-calorie foods out of the house, compensating for indiscretions. But probably the most important thing, I believe, is consistent limit setting in the household and with the caregivers, and making sure to enforce those limits consistently, not giving in if the child has a temper outburst, because that just tells them if they have a temper outburst, they can get what they want. And there's an important role for growth hormone improving. At the very minimum, the growth hormone will improve the tendency to spontaneous physical activity, which can help with burning calories. Other issues, the decreased saliva can be can predispose to choking on food and contribute to speech problems, as I mentioned, so we need to encourage liquids. Arrange for a dental visit at the latest by age 3, preferably earlier, and twice a year thereafter, if at all possible. In later years, there are special toothpastes, gels, mouthwash that can be used to stimulate the saliva glands and increase liquid in the mouth, but you wouldn't use those in infants. Constipation is a very common problem, probably related to intestinal hypotonia, as noted here. It should be treated aggressively throughout life, which can be done with dietary changes or increasing fiber and liquids, or all three, and in later years, if necessary, medication. We've talked about hypothyroidism already. It's present in about 10 or 20%. It could occur anytime, and it should be screened for at least on an annual basis. And really, the treatment is very simple, with just a small replacement of the hormones in a little pill. Growth, you've also heard about. This is a growth chart for Prader-Willi syndrome. Is this? Yeah. The dotted line is the normal population, and the solids are the Prader-Willi syndrome population, and this is without treatment with growth hormone. You see that the average is about at the level of the 5th percentile in the normal population with a lot of people falling below average and then falling off at the time that most people are having their adolescent growth spurt. That's very important for the provider to closely follow growth, and growth hormone should be continued if it's been started. We've already talked about vision, scoliosis, and sleep. These continue in infancy. It's important for parents to listen for snoring and restlessness during sleep and have a study if it's present. The doctor should continue to follow for scoliosis and the eye doctor for vision change. Later in life, there are many similar issues: growth, weight, exercise, diet, sleep apnea, eye problems, and scoliosis continue. Skin picking, I understand you had covered this morning. I was making a film for educational film, so I wasn't here for that. The increased pain tolerance we mentioned, altered temperature control and perception. A lot of people with Prader-Willi syndrome have no idea what is the appropriate clothing to wear for the weather and need some guidance on that. Precocious or premature adrenarche, that is early onset of pubic and armpit hair and often acne. Those signs can occur earlier than normal, and yet the remainder of puberty is often later than normal and not complete. I want to talk briefly about the risk for gastric dilatation, which I will do in a second, and cortical adrenal insufficiency. So these have been already mentioned. Continue to monitor growth, and if you have the possibility of growth hormone, continue that. The consequences of obesity in children are much the same as in adults. Cardiopulmonary compromise, increased risk for type 2 diabetes, although that's much more common in adults, obstructive sleep apnea, some tissue swelling and hygiene problems. Prevention is the same as it was for younger children. Diet, physical activity, firm limit setting, monitoring the environment, distraction can be helpful, and a dietitian if possible. And sleep apnea and vision problem and scoliosis as before. Skin picking can lead to chronic sores and infection, and there's no commonly used treatment other than keeping the hands busy. With some people have a little object to play with, and nails short and use distraction. But there's also some preliminary studies. Was this discussed earlier? Of it was, okay, of N-acetylcysteine may be very helpful for severe skin picking. For increased pain tolerance, I've had no fewer than 3 patients arrive in my clinic for a yearly follow-up that was scheduled long in advance, and they have a limp or they're not using an arm very much, and they say, oh, they had a little accident and they're recovering. And nobody looked for a fracture because they didn't complain the way somebody in the average population would complain about pain. So it's really important after trauma to have a good, careful physical exam for more serious problems than you might anticipate based on complaints of pain. Altered temperature control I talked about, and early signs of puberty. Stomach dilatation and rupture, I don't know if anybody covered this, but this is it was covered. Yeah, let me talk for a moment about that. How many people did not hear the morning talk about this? Okay, it's worth talking about. So this is a fairly newly recognized problem. It's not very frequent, but it's very serious when it happens. So I think it's really important to be aware of this as a possibility in your child. Again, it's pretty uncommon, but important when it does occur. It mostly happens in adolescents and adults, occasionally in an older child. It's a problem that can be contributed to by something called gastroparesis, which is a weakness of the stomach muscle. And what happens is that the stomach doesn't empty very quickly. And combined with a backup of stool from constipation, it can lead to the stomach getting very dilated, especially when there's been a large intake of food. And for some reason, it seems to happen more often in people who used to be very heavy and then lost weight and may have stretched out their stomach so that the wall of the stomach is thinner than it should be. And the symptoms are that the child or the individual is vomiting, has a decreased appetite, something that should be a red flag in anybody with Prader-Willi syndrome, actually complains of pain, and has bloating and an enlarged stomach. That's typically what you see. So because people with Prader-Willi syndrome rarely vomit, most people, and because they rarely complain of pain, when you see those things, it's worth immediately getting evaluated. It's a medical emergency. The stomach gets very dilated and the tissue can break down from lack of oxygen, the stomach wall, and can rupture. And when that can happen, if it's not treated immediately, it could lead to death. So it's something to be very aware of, very uncommon in young children. Occasionally happens in older children, mostly happens in adults, but it still is an important thing to think about. Cortical adrenal insufficiency, as you've heard, is the inability of the body to respond to physical stress by producing enough cortisol, which is something that helps the body cope with stress. The adrenal glands are little glands that sit over the kidneys and produce cortisol. This cortisol helps during severe illness, trauma, surgery where you have a major physical stress to the body, and helps to recover from infections. And it also helps to maintain blood pressure and other heart and lung functions. There have been a few studies, as was mentioned. One showed a pretty high incidence of problems with cortisol, and others have shown far lower. They use different tests for assessing the cortisol, and it's very hard to know how big a problem this is. But if you're aware of it, then if your child has a serious illness, infection, trauma, you can mention it to the doctor and make sure that it gets assessed. Currently, we're not necessarily recommending that every child be evaluated for it. So I just want to conclude by re-emphasizing how the future is very likely to be even brighter than the present is compared to the past. Improvements will occur. They're going to happen through individual and collaborative efforts of researchers and doctors, through national support organizations, Prader-Willi syndrome AI being a prime example, that provide education and advocacy, and through the International Prader-Willi Syndrome Organization, which you'll hear more about from Giorgio, but that provides a forum for doctors from all over the world and researchers from all over the world to get together and inform one another, form collaborations, get ideas through synergistic activities. And this will lead to more research, more drug discovery, and a better future. How can you help? Well, keep updated through your country's organization. Participate in research, as you've heard, that's so critical. And try not to forget those who are less fortunate, who live in countries where knowledge, services, even a diagnosis is not available, which is, and addressing those issues is the mission of the International Prader-Willi Syndrome Organization. There are many resources of information for families, for providers and doctors, and I've listed a few of them here that are more focused for medical care providers, but spread the word. And I thank you very much for your attention.